The jersey finger. It's a flexor tendon injury. You're grabbing a jersey trying to tackle your opponent, or you're holding onto a gi, or maybe your finger gets caught in the cage when you're being taken down. The opponent pulls away. Your finger is forced straight while you're actively flexing, and pop! The tendon that flexes the tip of your finger tears right off the bone. That's a jersey finger. Welcome back to Cut to the Bone. In this video, we're talking about one of the more dreaded hand injuries in sports, the jersey finger. I'm Dr. Lucius Pomerantz, a hand surgeon who fixes these injuries. I'm also a grappler who definitely does not want this injury. It got its name from sports like rugby or American football, where the jersey is often grabbed trying to tackle your opponent. Interestingly, the injury most often happens to the ring finger. This may not seem intuitive, but the ring finger is crucial to grip, and when you are trying to grab, it actually is the longest finger. So it's the one that's most likely to be forced into extension. What exactly is a jersey finger? Well, we got to do a quick review of the anatomy. The fingers have three little bones: the proximal phalanx, the middle phalanx, and the distal phalanx. The proximal interphalangeal joint is between the proximal and middle phalanges, and the distal interphalangeal joint is between the middle and the distal phalanges. To flex the fingers, there are two main muscles and their corresponding tendons. The first, the flexor digitorum superficialis, the FDS. It's called this because it lies more superficial or shallow compared to the other muscle as it leaves the form and goes into the hand. It goes down and attaches to the middle phalanx, these ones right here, that flexes the PIP joints. The flexor digitorum profundus, the FDP, attaches to the distal phalanges, and it bends the finger at the DIP joints. And because it's traveling all the way, it's also flexing at the PIP joints. These tendons travel through a flexor sheath within the fingers. This is made of pulleys that allow for motion, but keep the tendons from bowstringing away from the fingers when we grip. So, a jersey finger. This is when the FDP pulls off the distal phalanx. It could pull some bone with it. It could retract a little into the flexor sheath, or it could pull all the way into the palm. And if that happens, it means all of the blood vessels that nourish the tendon have been torn too, which is bad for healing. There is a whole classification system that us hand surgeons keep in mind, but we do not need to get into those details right now. There are a few things to remember. 1. Injured tendons in this area also can affect the flexor sheath. The sheath can scar in and close off. The injured tendon can adhere or get stuck to the wall of the sheath. If the sheath is in bad shape before surgery, then it also needs to be addressed during surgery for good outcomes. And we certainly cannot just cut the sheath away, as it has an important job. The sheath and how it heals affects rehab and healing of these injuries. Also, it is important to realize that the individual tendons of the FDP have a common muscle belly in the forearm, and therefore are very much linked. For example, you can try to make a tight fist with your small or your ring fingers straight, and you'll notice how the other fingers do not flex as far. If one finger is not working very well, it affects the other fingers too. The fancy term for this is quadrigia. So, clinical diagnosis. The classic sign is an inability to flex the DIP joint of the finger, but you can still flex at the PIP and MP joints, which is why often this injury is dismissed as just a jammed or sprained finger. When there's pain and swelling, it can be hard to determine what is limiting the motion. Sometimes you can see on X-ray or even feel a small avulsion fragment that is retracted down the finger. Unfortunately, in athletes, delayed diagnosis is common. They try to play through it, which makes repair much harder, which we will be talking about in a bit. So the management, non-operative treatment, no surgery. While it's always an option, it is not ideal. This is an option for an athlete only if they cannot take time away from their sport or their job. An untreated FDP avulsion, a jersey finger, means permanent loss of DIP joint flexion and the resulting weakness. Surgery is the standard of care. There are several ways of repairing the tendon back down to the bone. This can be with pull-out button sutures that go through the distal phalanx and on top of the fingernail. There are suture anchors that we insert into the distal phalanx, or a combination of techniques. And, well, if there's a fracture, you need to fix that too. If these injuries are caught late, we'll say after 4 weeks, then the flexor sheath begins to scar in and the flexor tendon can be in poor shape, leaving only 2 surgical options. 1, you fuse the DIP joint. This still may have some residual weakness, but at least the DIP joint is not flopping around. 2. Reconstruction of the FDP. Reconstruction means taking a tendon from somewhere else in your body. Often we use a tendon called the Palmaris longus, but about 15% of the population doesn't have it, and we use that to remake or reconstruct the FDP. Sometimes this can be done in a single stage, meaning all of it's done at the same time. However, this can only be done if the flexor sheath is in good shape. When the flexor sheath is scarred in, then we have to do a staged reconstruction. This is where, in the first stage, we place a silicone or plastic spacer along the path of the eventual tendon. And then we come back later, often after 3 months, to remake the tendon. A key to any tendon reconstruction, other than good surgical technique, is having good range of motion before surgery. This is often facilitated by hand therapists, and this is because the reconstructed tendon can only move the finger as far as the joints allow. If you're stiff, you can see my separate video on that. I can do a perfect reconstruction, and you still won't be able to move. So, the rehabilitation, the recovery after surgery, you have to expect a minimum of 8 to 12 weeks away from your sport. Hand therapy is crucial to the recovery. This is because you have to find a balance of restoring motion, where you're avoiding adhesions or scarring within the sheath without pulling the repair or reconstruction apart. It takes very skilled professionals to do this. I often tell patients that there is no point in me doing the surgery if they are not going to do the therapy. An athlete's returning to sport depends on a lot of factors, including their sport. But they can return when they have normal range of motion, no pain, and grip strength of at least 80%. This recovery is a lot like a fight camp. You don't jump right back into the ring after a layoff. Build your strength, you get your timing, and you make sure you're effective before you're ready to compete. So, to nail down some points, a missed or neglected jersey finger, which is easy to do, can lead to permanent grip weakness and or stiffness, both of which could be a disaster for athletes, fighters, grapplers, and surgeons alike. So remember, if an athlete can't flex the tip of their finger after a forced extension injury, think jersey finger. Get it diagnosed early, get it fixed, so you can get back on the mat or the field. If there is a delay, you may be looking at a staged reconstruction, which takes a long time, and you risk permanent loss of function. Thank you for your attention. Thank you for watching Cut to the Bone with me, Dr. Lucius Pomerantz. If you found this useful, please press that like button. Don't forget to subscribe, and please share this with your friends. And also, please drop a comment with other sports injuries you may want me to break down.